Okay. I'm recording this meeting for those who are playing softball and defending your name as occupational therapists. So hopefully.
Our games actually got canceled, so we're here.
What?
I know, the rain.
Oh, see?
Bad boss.
I know. Well, now you can leave with your dignity. You can say, like, I couldn't be there because of the rain instead of, like, exam prep. So. All right. Well, then do I need to record this?
Yes.
Okay. All right. So I'm recording this. Jennifer just texted me with the question, how do I get onto Zoom? So. All right. Let me resend her the email. Let's see. For that, she can do it. All right, let me get her going. Okay. I may have to just get her on speakerphone, and then you'll get her on speakerphone through Zoom. So we'll have to see how it goes. All right, so I'm recording the meeting. This is the midterm exam prep for OT 634. Exam is next week. I'm just about to put out an assignment. There were people who had field work on Tuesday afternoon. So we are going to switch the midterm and class. So what is going to happen is you're going to have the midterm in the morning and class in the afternoon so that those who have field work in the afternoon can make it on time. All right? So that's what's going to happen. Midterm will start for people with accommodations. It will start at 9 o'clock, and people without accommodations will start at 10 o'clock. Okay? So if you have accommodations and you are taking your exam either with us or with the Learning Center, it will start at 9 o'clock. If you just have the regular 2-hour testing time, it will start at 10 o'clock in the morning. And then lecture will be in the afternoon at what would have normally been our lab time. Is it starting at 1, Jennifer?
Yes.
Okay. So 1 o'clock will be lecture, and that will be the time. So you're not actually, changing any times or losing any times. It's just we had to switch it so that people had enough time without pressure to take their exams and get to their field work. I will put this in an announcement. We just got it all confirmed today with the Learning Center and with all of that.
And for lecture, because I know there are 4 people that have to leave for field work, and so that they don't lose content, we do have a video of Dr. Underwood talking about CBT for 30 minutes. So I'm going to show that the last 30 minutes. So that way you guys are all getting the same info.
Okay. That also will relieve your stress. You'll be able to, by the end of the exam, you'll be light and airy and feeling great about yourself and ready to go learn in 624 rather than stressing about the exam in that class, right? Everybody's going to ace it and you're going to walk out and it'll be completely fine. Okay? So I will send out that announcement, and just so you know, exam in the morning, you'll be fresh, you won't be tired, nothing will be confused. You'll take your exam, you'll feel good about yourself, you'll be excited to go in 6:30 and 624 and brag about how good you did. Okay? That's the plan for Tuesday. Monday, you can get a pedicure or a massage, and you can study frames of reference and sensory theory and spinal cord injury levels while you do that. Does that sound like a plan for everyone? All right. So I thought in order to start this that we would go through a couple of sample questions, and that may kind of stir your minds with things. Do y'all want to start with the sample questions, or do you have questions you want to ask?
Yeah, that sounds great.
Sample questions sound good? All right. I'm going to screen share with you, and we are going to use Poll Everywhere. So let me go ahead and do my screen share. We're going to screen share Google. Okay. All right. See? All right. So this is the first Poll Everywhere question. And in order to participate, you need to go to either pollev.com/AmandaBono110, or you need to text. This is the body of the text message is Amanda Bono 110, and the phone number is 37607. I'm sure you guys have used Poll Everywhere before. This is like the text message, and this is the number you're texting to. Okay? Okay. And I'm going to move mine over. Can you see the numbers on the page? Like I have people that are you seeing people on my screen when I share, or you don't see that? Okay. So you can see, you can move the people around in order for you to see the question and the answers, correct? Is that right? Everybody can see? Okay. Thumbs up? Okay. All right. So as you get logged in, you guys can answer the first question. Okay. The first question is, Andrew's a 17-year-old boy with Asperger's and anxiety. He wants to attend community college to study aerospace engineering. His parents have concerns about his plans since his grades were kind of on the low average sides, and he was suspended 2 times for verbal arguments with teachers. One assessment that may shed light on this situation would be A, the Tennessee Self-Concept Scale, B, the Pierce-Harris, or C, the BAFPI-SIS. Tell me which assessment you might pick. Hopefully everybody's logged in and is answering. Go ahead and a few more. All right. There's no phoning a friend with this, okay? I see you guys over there talking. All right. Here we go. Let's see what you guys came up with. All right. Most of you picked the BAFPI-SIS, and the answer is wrong. Oh, man. I would have picked the Tennessee Self-Concept Scale. The BAFPI-SIS is used to look at social interactions in an environment that is like a group or an inpatient environment, right? So it's things like they have meals together. There's a group setting, a small group setting, a one-on-one interventions. It does not look at social interaction scales in general. So then you're looking at self-concept scales. Is it the Tennessee or the Pierce-Harris? So the Tennessee is this Likert scale of 1 to 5, gives you more detailed, is more intellectual. And the Pierce-Harris is going to be the yes or no scale, the nominal scale, and less detailed. So a kid who has average or above average cognition, or is able to do it, doesn't have any attentional issues that we mentioned. You want Asperger's kids also have difficulty qualifying like the yes no. So the Likert scale might be easier for him. So that's why I would have picked the Tennessee Self-Concept Scale. Are you understanding what the cues are there? Does that make sense now that we walked through it? All right, we're going to try another one. Okay. All right, let's activate this. All right, so here's the next one. A 24-year-old student with depression says they have no friends or hobbies due to time. They don't have enough time is what they say. What assessment would you consider using? The OPHI-2, the OCARES, Assessment of Occupational Function, or the Tennessee Self-Concept Scale? Which one would you use? Look at the cues in the question. What assessments do we look at for that? Okay. Anybody else? Any of the last minute? Go with your gut, people. All right. I'm ready to show results. Are you ready? Drum roll, please. Oops, sorry, wrong one. Show results. The answer, yay, the assessment of occupational function. Does anybody who got that answer want to share why that you picked that one?
Well, I picked it because they say that they have no friends or hobbies due to no time. And so that way you can kind of see, like, what does their everyday look like for a weekday or a weekend. I felt like the OPHI and the OCARES looks more at, like, past history, maybe, like, traumatic. I don't know. I just didn't choose those because I didn't think that maybe their traumatic history was very important.
The OPHI has that history piece. The assessment of occupational function does have that timeline piece. So somebody give her the high five next to you. There you go. Good job. You got it. That's it. The cue, the word that you were looking for was the time piece. That would allow you to look at and to have them look at how their time use is, what their time use is. Okay. All right. So you are working in a day program with people with chronic and persistent mental illness, many who have schizophrenia. When implementing the alert program with these clients, they would benefit most from A, move, B, mouth, C, look, listen, or D, smell. We're looking at clients who have schizophrenia. What sensory input would we find most beneficial? All right, a few more people want to get in there under the wire. I know you're feeling confident about this one. So let's see what we've got. Move. That's right. Move. Anybody want to answer why they picked move? Lucky guess? Because it was A.
Isn't proprioceptive the first thing you would address with these people?
What do you mean these people? Like the population of schizophrenia or just people with sensory processing?
Schizophrenia.
I thought the outcomes that I was looking for was when Lorna Jean King did her research. She came up with some of the things, some of the first activities that she looked at and found most effective was movement. And
well, and vestibular and prope.
Yeah, that's what I meant.
Yeah. And vestibular and prope are both under move, although you can get prope in mouth. So
more consistently found in move, and kind of one of the things that we would think about doing. And Jennifer talked about tempering movement based on a person's movement history, but just based on King's research and what she found, vestibular and prope in this population were very effective. Okay? Are people going back and changing their scores? There's no like scoring after. Come on.
No,
not a
I just had to add mine because my computer went crazy. So I didn't have the question answered, so I just answered it.
Oh, okay. Yeah. Uh-huh. Likely. All right. Let's go on to the next one, okay? All right. So this one is just kind of a word cloud one. So here's what I want. I want you to text 1 to 2 word responses for conditions, occupations, and interventions associated with the sensory stimulation. So what conditions would you address? What occupations would you address? What interventions would you associate with any of the strategies? So let's see what you come up with. Well, here we go. Mood disorder, substance abuse. Look at these people go, Jennifer. Aren't they smart?
Mm-hmm.
All right. Sleep. Ooh, that's a good one. Alerting. Wake, anxiety, autism, depression. And the more you use the words, the bigger they get. Aromatherapy, sleep-wake cycles, strategies. What are some other strategies? Sensory diet. All right. Alert program, it's right there, good. Okay. All right. It looks like weighted blanket was one of them. Work, regulation, TBI, okay. Noise. You guys are so smart. Look at this. Okay. So it sounds like you're right on track as far as conditions that you can address. Some of the occupations are a little more limited. I see sleep as one of them, but don't forget that it's not just calming that you can do, but alerting as well. So, you know, getting people up and moving to engage in occupations as part of their morning routine or a part of, we talk about work strategies or even participating in social engagement. For when you have those people who are heavily medicated or people who are severely depressed or, you know, those are the people that we would want to alert, and then we want to provide calming strategies for people who are agitated or anxious. So don't forget to come at it from an occupational perspective, and don't forget to be a little more diverse in your strategies. I see aromatherapy and I saw weighted blankets. Just verbally, has anybody else come up with anything else?
I was thinking about wearing tight clothing, like a tight undershirt for some compression,
Okay.
Yeah.
or like chewing on things.
Mm-hmm.
Yeah. The types of foods and stuff. Good.
And when we talk about occupation, also don't forget roles. So maybe they're a student and we implement a sensory diet to help them alert and maintain or calm, right? And even for people that work.
Yeah, modulation piece. Okay. Anything else?
That
I
looks
know,
good.
like, I was just gonna say, like, one method for like abuse victims, you can like read your Bible. That's calming.
But
That
what
was in my
sensory
Bible.
system is it?
Well,
See, that's the thing that you guys struggled with when you were doing your sensory strategies, is that you talk about mindfulness, and mindfulness can be a sensory system if you're doing like guided imagery, or, you know, you're doing some of the like the auditory
The
guided,
breathing.
the breathing visualizations. But just mindfulness itself is not a sensory strategy. You have to tell me what sensation you're targeting or what sensory system you're working on. And remember, those 5 in the alert program are a good way to kind of categorize, right? So even though, like, there's a lot of calming strategies out there that are not necessarily sensory. So I read my Bible to calm all the time, 2 thumbs up. But doing it while breathing lavender or under a weighted blanket, or in my rocking chair, or eating Twizzlers. That's my sensory diet. Does that make sense? Don't forget movement. It seems like, that there's not a ton of movement in here. Movement can be a good one. Even doing, anything to massage or touch, or for those who don't like touch, we talked about some of the other things, but this looks good. You guys got a good start on that. 2 thumbs up. Okay. All right, on to the other questions. Okay. All right, you're working at a day treatment rehab that specializes in working with people with brain injuries. You have an 18-year-old named John who can follow parts of a conversation, but he tends to forget parts of them. He can do his basic ADLs with help. He also seems to be more aware of his physical problems than his cognitive problems. What Rancho level of cognition do you think he would be rated at? Okay, just for the sake of time. You guys are smart cookies. He's a 5. Good job. Very good. So what cued you into it? For those who got it right, help your classmates know what to look for. Can't be all dumb luck. Come on. Who got it right? Why did you pick it?
The right answer was 5, right?
Yes.
Oh, okay. The one thing I could remember is that people at the level 5 might need assistance with ADLs. So that's why I put 5.
All right. So he could do most of his with help. He could do ADLs with help. Okay, good. All right. Anything else?
Can you explain why that wouldn't be 6? Because I thought it was 6 because it talks about how he's more aware of his physical problems. Like he starts to become more aware of that on level 6. So I was kind of confused there.
I would have to look at it to tease it out, but I think it's the I thought that level 6 is he becomes more aware of his cognitive problems. That they're aware that 5 is the concrete and 6 emerges a little more into the self-perception. Am I reading that wrong, Shelby?
I wrote it today, so I may have written it wrong. I can double check too on the
Okay.
sheet or whatever. But that's
I'll go
why.
back. That was my understanding, was that it's the very concrete, list-oriented, ADLs with, queuing and things like that, and you become a little more aware with 6. So I'll look back at it. Maybe I'm wrong too, but I thought it was a 5.
Okay.
All right.
I'll double check too.
Okay, thank you. All right, onward and upward. At this point in your treatment, when trying to teach John new occupations, what would be the best strategy for use? Doing therapy in a quiet location, focusing on doing ADLs independently, doing therapy later in the afternoon. All right. Let's see what we've got as far as results are concerned. Doing therapy in a quiet location. That's the best strategy, okay? I could see where you would talk about progressing on to the next level, but until his cognition level had progressed, he's going to need that extra assistance. So Doing therapy in a quiet location is a good strategy to make sure what you're doing, no matter what it is effective. And he's going to be as calm as possible. Okay? Moving on. All right. Here's a good one. John wants to live alone, but his family is concerned about his safety. What would be the best assessment for you to look at? The EFPT, the BATH PTOA, the KELS, or the weekly calendar planning activity? Executive Functioning Performance Test, the Bay Area Functional Performance Evaluation Task-Oriented Assessment, Coleman Evaluation of Living Skills, or the weekly calendar planning activity. Which one is the best one to assess safety in independent living? Should I sing like the Kahoot song? No? All right. Doesn't seem like everybody's participating. Are you trying? It doesn't hurt to try. Nobody knows what you answered. It's anonymous. Go ahead and put yourself out there. All right. Let's see. The answer for all my baby geniuses is the KELS. So proud of you. Heart, heart, heart. Did it. The KELS is looking at discharge planning, rates independent or not independent, and has a big area on safety. You guys got it. All right. An intervention plan for a person with a complete spinal cord lesion of, I can't see it in the corner. Is it C5? Does it say C5? Jennifer, yes or no?
I can't see it. It's occluded.
Is it occluded by all of you guys?
C5.
C5 has been developed by a client, an occupational therapist, which would include what of the following? Okay, what would you consider for C5? Looking at independent living. So A, voice-activated technology. B, self-feeding and grooming. C, sliding board transfers. Or D, self-cathing. C5, what you gonna do? I know you guys know this. All right. Results are self-feeding and grooming. Does anybody want to say why that was the one to work on?
Because at C5, they start getting that elbow flexion, so they should be able, with the help of like a universal cuff, to get stuff to their mouth.
You are so right. Good idea. That is a great idea. All right. So, if you have a C5 injury, what would you need? A manual wheelchair, a mouse stick, universal cuff with a wrist support, since Kayla just ruined the big finish for us, or the short opponent splint. Spoiler alert, spoiler alert. She's on top of it. She even predicted the next question. Ah, yes. I'm so glad that y'all are paying attention. Good job, guys. Very good. All right. Let's go on. Jack is a 34-year-old veteran with post-traumatic stress disorder. He is in a 2-year court-ordered veterans therapy program for multiple DUIs. In his first group meeting, the OT observed Jack's social participation, his functions, and his behavior before the session, during the group session, and after the group session. The student then used the document and documented the observations as a benchmark for progress. Based on the information given, what assessment was the OT student using? She looked at social participation, functioning, and behavior during his group session, and she's using it as a benchmark for progress. What assessment is the OT student using? Right? That is right, boys and girls. She is using the coat. You got it. Looking at the 3 areas of function: social participation, functioning, occupational function, general behaviors, and it can be used as a benchmark and observed later on throughout using it. So that is correct. Good job. All right. Bob is a 36-year-old male with dissociative identity disorder. He's in a hospital for observation following a psychotic episode. The nurses report that he has difficulty interacting with the other patients in the hangout room, but seems polite during his exchanges with the nurses while she's giving his medicine. And based on the comments, what assessment would be most appropriate for Bob? What are we going to do with Bob? There used to be a movie before many of you were born called What About Bob? What About Bob? Jennifer, did you ever see that movie? What About Bob? No? Maybe Netflix has it. All right, let's see what we're going to do about Bob. Yes, that's right, people. We're going to administer the BAFB SIS because we're looking at social interaction in a variety of settings. Good job. Okay, I think you guys are getting the hang of this. You're hosting a sensory music group with a group of clients that are nonverbal. To measure participation and engagement during the group, what assessment would you use? That's right, the volitional questionnaire. The cues for that one are that they're used with people who are nonverbal or lower functioning. You're looking at just attention, engagement, participation. There's really no social interaction to measure. There's no typically interaction between clients in these groups. You're just looking at their participation in the group. Okay? All right. Andrea is a 40-year-old female with schizophrenia who attends a community peer support group 2 times a week. After administering the coat, the OT notices that Andrea scored higher on non-productive behaviors and activity level hyperactivity during the group after lunch. This might indicate that A, Andrea showed improvement in general behaviors after lunch and less support is required. B, Andrea's activity level and non-productive behaviors are more significant after lunch and she would benefit from sensory strategies to address them. Or C, Andrea's activity level and non-productive behaviors are significant after lunch and she would benefit from social skills to address them. Tricky, tricky. What are we going to say? All right. The answer is B, that a higher level score in the coat indicates a decline in behaviors, and because of the type of behaviors that were targeted, sensory strategies would be appropriate. Very nice, ladies and gentlemen. Thank you. Oh, I think that is all of our questions. That's all of them. That's all of my questions right now. So, you guys have questions for Jennifer or I? Jen, do you have any questions off the top of your head that you want to pose to them, or you think that that covered a broad base?
I think that hit all of them. Just remember, the week that we were online, there were 3 PowerPoints about, one was adult DD, one was sensory with adults, and then one was adolescents. So
Make sure, yeah, you get all 3 of those topics.
Yeah.
Okay. All right.
Dr. Allison, I think you had mentioned at one point that you were going to put up a recording for the adolescence one that week.
Yes, I looked and I didn't have it. It was still the regular. So yesterday, I think it was yesterday, I posted a narrated one.
Okay, thank you.
In 624.
Okay.
Mm-hmm. It's long. I'm sorry. I just talk and talk.
No, not you.
I know, right? I was listening to one of Mary's narrated things, and I was like, man, she is just like to the point. Chop, chop. Not me.
I had a question about the self-concept assessments. Professor Bruno, you were talking about how you would choose the Tennessee over the Pierce-Harris. Can you kind of explain, like, how you pick between those when you have someone that is within age range for both?
So the it breaks down to, they measure very similar things, but the Pierce-Harris has a yes-no scale and less questions. And the Tennessee has a Likert scale and more questions. So it comes down to, if a person is pretty concrete or has an impaired attention span or has difficulty, answering questions, that's the yes-no piece. If you're going to lose them when you're just giving them the scale, 1 means this, 2 means this, 3 means this, and they're gone. Like, you're not going to get through 50 questions of that. Then you're going to give them the Pierce-Harris. Anytime attention span is an issue, you're going to give them the Pierce-Harris. Anytime concrete is an issue, you're going to give them the Pierce-Harris. Now, a functioning adult or a person who has average cognition, they can't always say it's always yes or always no. So they're going to want the variation to describe how their behavior applies. Do you have trouble making friends? Yes or no? Well,
It's like
not
sometimes.
yes and not always no's. Yeah, it's like, most of the time, some of the time. So those are the things that I would look at, is if a person can answer some of those more abstract questions, then I would ask the more abstract questions. If attention span or cognition are an issue, then I would use the Pierce-Harris.
Okay. That makes sense.
Did you guys have questions about any of the questions? Anything else that?
I did. So with the schizophrenia, and it was between choosing the sensory and the social skills, I was pretty close with those two, because I was thinking, like, during lunch, the socializing might have sent her over the edge, or like the sensory input from the food. Like, I guess I was just kind of like, I just want to see your reasoning behind that so I can kind of follow more.
Was that the coat one?
The coat, yeah, the score question of what you would do, the higher score indicated. So the 2 things that it indicated were hyperactivity and non-productive behaviors. So those were the classifications that it indicated. So when you see a person who has more hyperactive behaviors and is stimming more, what would that indicate to you?
That they're overstimulated.
Right. And so even equipping them with social skills, they may not be able to hear or process what you're teaching them until you get them into more of a calm, alerted state. So I would think of social skills training as being like a cognitive intervention. I mean, you're addressing the concepts through cognitive strategies and educational models and all of this kind of stuff, but you can't get to cognition until you have that foundation of sensory, calm, alert state. So that was my reasoning.
Thank you.
Other questions?
On the study guide, you like didn't indicate that we were going to have frames of references. So are the frames of references the ones that we learned in lecture at the beginning of the semester that are basic mental health, like psychodynamic, biological, humanistic?
You won't have to answer a frame of reference question. So I won't ask you, that's more of a 624 thing. I will, or Jenna or I won't ask you the question where, like, approaching someone from this frame of reference, except for sensory, which we addressed. Sensory is a frame of reference, right? You won't have to address that per se. But if given a question, you know, like an approach, how would you approach them? What would you consider? These are, you know, things that you're going to have to know as a background. You know, if you were suggesting an intervention for someone, those frames of reference help you dial in with how to approach people. You know, if you were addressing people who had mood disorder or depression, you know, what you found out, what frames of reference would you kind of dial in with so that that would help you pick out the right interventions to address. Does that make sense? There's very little name or label, or it's more like, given this case, what would you do? And the frames of reference just kind of help you focus that. Okay?
Can we go back to that spinal cord question? Or not, the brain injury, the Rancho-Los?
Uh-huh.
I have it pulled up, and some of the same things that are in the question are with level 6.
I may have misread it too. Let me go back and look. Okay.
I just wanted to address that while we were all together.
Okay. I hate to steer you wrong. Are you looking at the PowerPoint from Shepherd, or where are you? What is the source? The one I had in 634. What was your source?
It's the PDF. It's like Biocognition PDF, and it's the Patient Information Family Guide to the Ranchos Levels of Cognitive Functioning. And it explains what the person does at the level and then what the family and friends can do at that level.
Okay.
Would you recommend we look at the one that Shelby's looking at, or would you recommend we look at the PowerPoint?
The one I posted with the Biocognition, I think, breaks it down pretty well. They should be fairly similar.
Okay.
I have a question. So the one, it was Jack who had the veteran with PTSD, and the answer was the coat. Can you explain again why you would choose the coat over the BAFI?
Which one? I didn't hear her. What was
the veteran?
Oh.
Jen, do you want to answer that one, or do you feel comfortable?
I don't know if I remember it. Tell me, what was it again?
It's the Veterans Court, why I would pick the coat over the VAFP, because I was measuring 3 levels of things for him: functional behaviors, or function, occupational behaviors, and social interaction, whereas the BAFP only looks at social interaction. The second thing is, if you're working with them in an anger management or a DUI group, you're not going to
court
5 settings.
You're only in one setting. Now, it's not setting though. So it's more the structure or the context, because it can be in the same setting. But there were really only 2 or 3 things that were described in that, like before group, during group, and after group. So like you have the unstructured, the structured, right? The different ones, but you didn't have all 5, and you wouldn't have all 5 in a court.
You wouldn't have
program.
meal times or one-on-one or those kind of things. So you have to consider also that you can get more information from the coat, and it can be a baseline measure that you can repeat throughout to monitor functional levels.
I have something written down in my notes about like the coat having no testing bias. Does that have something to do with that question too, about how she was able to administer it like several different times back to back?
Well, not the testing bias, but you're looking at that person scored against themselves, right? So we're looking to see growth in that person. And so that's another reason that it would be good.
Oh, maybe I'm reading. No wonder I'm reading this wrong. Apparently. Shelby, I do see your point about the cognitive level 6 because it lists ADLs there and short attention span. So I would take 6 for that.
For when we're deciding between Rancho levels, let's say like from what we saw, like it was a thing with Shelby, like Shelby saw a few things at 6, I saw a few things at 5, like if it was like, okay, you have to pick one and there was only a right answer or something like that, would you go with the lower level because they're showing signs on the lower Rancho level, or would you go with the higher level because like they show that they can reach the higher level sometimes, if that makes sense?
If I were looking at the question and they had like 4 indicators and 3 were in one level and 1 was in another, I would go with what had the most indicators.
Okay. Not necessarily like higher or lower functioning.
Right. So where the majority of the indicators are.
Okay.
I will try to make it a little more clear cut. Okay. Any other questions? How did you like the case-based questions? Because those will be similar to what you will be seeing on the exam. All right. Lots of people with a diagnosis of a certain age, in a certain setting, addressing certain occupations. And that's why sometimes it is that we allow you to have paper. Like if you want to write down what the keywords in the question are, that's a good strategy for the test. You know, if you're like, you would think about almost underlining, okay, this is the person, this is the diagnosis, this is the setting, and there's usually 1 or 2 other keywords that are steering you towards something. Okay?
I have a question. So the cognitive assessments, I know the KELS is like the one that determines the ability like to go out their basic living skills. So I guess I'm just having trouble like with the other 3, like especially the task-oriented assessment and the EFPT, deciding when you would use which.
Okay.
Maybe that's just me.
So anybody remember anything about the BAF PTOA, the task-oriented assessment? How much of it was really occupation-based?
There's only one, like, was it money management or medication management? I can't remember which one
Money
it was.
management, yeah. That was
Yeah, and-
occupation-based.
Yeah, the others are like sorting shells and stuff. So I feel like maybe if somebody was like if they needed that cooking, I don't know. That's a good question, Kayla. That is kind of tough because they both.
So the EFPT definitely had a wider variety of functional assessments, right? Cooking, money management, the medication management, and the phone use. So very pragmatic, occupation-based assessment. So if you're looking at people, you want to look at their cognitive abilities within their daily life skills, the EFPT is a very good measure for that, right? You're looking at people who are transitioning to different environments. You want to see if they're going to be able to learn new stuff. You're going to see how much assistance they need because it's got a queuing level, remember? But why would we use the BAFB? Anybody remember anything about the BAFB?
I almost want to say, I don't know this is right, but maybe like lower functioning? Because they don't do like the actual thing. They do stuff like.
Isn't that the one that's the gold standard?
I'm sorry, what, Taylor?
Isn't that the one that's the gold standard and you want to use for like if someone's trying to get disability or in a court case, you want to have something that's like highly researched and standardized?
Yes, it's old as dirt, but it is highly standardized. It's a lot of reliability and validity data. So when you need those gold standard measures, like applying for disability benefits, court cases, any type of standardized something you need reimbursement, or maybe you're trying to validate a new measure, or you want to look at it in practice or something. Those are when we pull out the oldie but goodie, has to be on the test kind of thing.
Okay.
And it's looking more at client factors.
Yes.
Whereas the EFPT is truly occupation. And some people might argue there are times that you have to ferret out what is the client factor. Do you know what I mean? So like a further testing, perhaps.
So is that like the only thing, like you would really just use the BAFB for that reason if you needed that extra support behind you for the disability? Like that was I knew all of that it was stuff for that, but I just didn't know if with an actual like patient, like that would be the only reason that you would pick that one.
It has been normed on a wider variety of folks. So almost every type of psych diagnosis. Some of these other ones, it hasn't been looked at as extensively across all populations.
And I think it's also been used more in hospitalized clients, whereas the EFPT is more people who would be on like an outpatient basis.
Well, and if you think about like my level 2s this summer, we really wanted to do a functional task, but we have like a little office over at the court place and we don't have access to a stove or a microwave. So I couldn't give that portion of the EFPT. So, we were limited in that way as well. So you have to look at pragmatic clinical reasoning would be, okay, I don't have a stove. I don't have, you know what I mean?
Okay. Thank you.
Mm-hmm. But I agree, I don't love it. Kind of like handwriting, you're going to give yourself a nice standardized handwriting assessment if you're trying to discharge somebody, right?
Mm-hmm. All right, anything else? We're melting, people. We're cognitively melting.
Yeah.
I have a quick question. Under considerations or interventions for an section of the study guide, you have just chronic and persistent mental illness. Do you want us to focus on certain diagnoses like major depression, schizophrenia, OCD, or that kind of umbrella term?
All right. I said what? Okay.
In the study guide, number 5 is considerations for and intervention plans for people with ... And then you have sensory processing disorders as chronic and persistent mental illness.
Yes. So in the slide presentation, when you're looking at sensory processing disorders, it talked about schizophrenia specifically, but it also talked about like mood disorders, bipolar, some of that in there.
Mhm. And remember, I told you guys to really look at the Katana Brown research. There was some information in some of the slides about Brown and Dunn and norming and standardizing the adolescent adult sensory profile on people with mental illness. And it was severe mental illness, although they also did do other ones. I was like, make sure you read that. So.
Okay, thank you.
Mm-hmm.
I have a question about the Asia testing. Sorry, I'm trying to find it. It says for sacral sparing, or for complete injury, there's no sacral sparing, and then incomplete. Is there still no sacral sparing, or is sacral sparing present? I was confused about like the complete and incomplete.
So, according to the Asia testing, let me pull it up because I'm trying to remember. It's been so long. I thought incomplete there is sacral sparing, but I thought it was with motor nerves, not sensory nerves. That's just my thought, but let me see what I got. Do you know what sacral sparing is?
The sensation.
So maybe I got it wrong. Where's my?
I don't know. I was just confused about that in general.
Okay, so sacral sparing is that the motor loop that causes the reflexive, like the upper. Testing.
On my study guide, I have that both both C and D have sacral sparing, which is both motor and sensory.
So then it's saying that in order to be a complete injury, you do not have sacral sparing. All of the others have sacral sparing. Isn't that what the case is?
Oh, wait, no. I read it wrong. So it's the C and D are both just motor. So B is sensory but not motor, and the sacral segments are involved. So you're right. Motor, sacral sparing, sensory involved. There isn't sacral sparing.
So I'm confused about what I said now. Did everybody hear what Kayla said?
Okay, so what you said first was right, and I kind of screwed it up there. I'm sorry. The sensory, like if you have sensation but no motor, then you do not, you're like the sacral segments S4 and 5 are affected. But if you have motor at all, then you have sacral sparing.
Okay, according to the slide number 21 in the presentation that was in 634, it outlines it for us. Do you want to see it on my screen? Just let me screen share with you. All right.
The SCI classifications.
So right there, that's slide number 21 that's posted in the module. What I would more know about this is, if given one of these things, would you be able to identify an Asia A, B, or C? And then what are the functional implications for this? What does sacral sparing mean? Okay. And that goes back into the reflexes that are present.
That was my question. What does sacral sparing actually mean? Is it the sensation and the reflexive?
It's not sensation, it's reflexive.
Okay, that's what I want to make sure.
Okay. All right, any other questions? All right, guys. Guys ready to call it a night? Okay. All right. I will see you guys Tuesday morning.
Thank you.
All right, 9 o'clock for people who have accommodations, 10 o'clock for people who don't have accommodations.
Well,
And
we won't see the people that have accommodations.
we do have people who have extended time but not distracted. So we will see them.
Yes. Yes.
So we'll see you at 9 o'clock for those people. Remember, you're leaving your backpacks and everything, already unpacked. You're coming in quietly, setting your stuff down and getting started, okay? So we will have announcements up or things written up on the wall, but you got to be quiet for those of the people who are already in there and getting started. All right? All right.
Sorry, you might have said this. Is it in the boardroom or is it in the classroom?
The ballroom. It's in the
It's in the freezer.
Bring your wool socks and your blankets. If you are planning on taking your exam, the Learning Center has it reserved in the Red Wine computer lab, which is in the library. If you're planning on taking it there for your distraction-free environment, you have to email them and let them know. And please attach us to that email so that we know you're going to be there. So you need to do that probably by tomorrow if you are planning on taking the exam with them. All right, everybody else we will see on Tuesday morning in the freezing cold ballroom.
Do you have any weighted blankets that you could spare?
Do you want us to diffuse while we're going? Diffuse?
I tried to diffuse and it wasn't even, it's so big you can't,
can't even touch it.
Yeah. Well, that's okay.
All right. All right, guys, have a good night.